Welcome everybody to week 7, disease and disorder, illness, issue, and the broad topic of medicine on, of, and off with 2F, the brain. This is one of the most pragmatic, application-based parts of this course, and we will have the chance to talk about the connection between fields, but especially the connection between neuroscience and medicine. Now, I would like to start our conversation by examining the subtitle, one of the subtitles of this section of the chapter on medicine on, off, and off the brain, which has to do with to treat, to heal, and to cure. Now, as you know, at this point, I really like to talk about words in all my courses to clarify some ontological and etymological aspects of the jargon we utilize, but I feel that this is especially important in this section of the course. Now, to treat, to heal, to cure, why is there a need in a course on neuroscience to discuss these three topics, these three words, the scriptures? Well, for the simple reason that one of the standard application of neuroscience is to help us understand better the way we function, the way our body is structured, and what parameters our brain follows in order to account for behavior and emotion and cognition, and also for the perspective of neurogenesis, neuroplasticity, and the ability of the body to heal itself. So, three words: to treat, to heal, to cure. Now, I would like to start with the first one, to treat, and this is one of those terms that are very broad in the way it describes our clinical intervention, and also represents a connection between mind and body, because you can say that a person might be more or less apt to treat mental health disorders, medical disorders, to treat temporary conditions, to treat chronic problems, to treat localized, specialized problems, as opposed to treat the person as a whole. And as you would imagine, in the latter case, treating the person as a whole, this would be the realm of those integrative, complementary, and alternative medical parameters that, of course, should have the patients at the center of therapy. And this is a whole other discussion, a fascinating topic that if you'd like to find more about, I will recommend you take a look at other videos that I have posted in that specific area of teaching, and there are courses dedicated to that topic specifically. I will add the link below. But in general, the idea is this: you are more likely to be able to help a person if you understand the parameters according to which the healing process occurs. And so from the perspective of treating the person, you will help the body foster its own healing process, its internal healing process. We mentioned some of that in the context of those neurotransmitters, chemicals, hormones that are at the center of pain receptors. If you think about what we said about dopamine, what we said about the gate control theory of pain, what we said about enkephalin, what we said about beta endorphins in the context of physical exercise, for instance, and this general idea of endorphic inner proper way the body understands how to heal itself by virtue of creating this cascade of neurochemical processes that support that pathway. So again, what do we mean by medicine on, off, and off the brain? Well, in the first case, medicine on the brain, well, this simply identifies the clinical argumentations, processes, and discussion on the way medicine acts on brain structure in order to foster the healing perspective and to foster prognostic discussion in this area. So a medicine that is applied on the brain, that's the first clinical element. Medicine off the brain, that type of medicine that again has to do with those very ingredients that are pretty much the neural correlates of body function. So the main area of the discussion will be pathophysiology, for instance, and in a broader sense, neuropsychoimmunology, to give an example, medicine of the brain. The third one is the most philosophical of them all, medicine of the brain, as in separate from the brain, not because the brain is disregarded as important, because it is a type of medicine that goes beyond brain function, and dare to say beyond body function. And this is represented by the discussion of mind-body connection, so as in focusing on that part of that interaction between dualism and monism, where mind controls the body. And so medicine of the brain is a type of medicine that fosters inner guidance, I dare to say, that definitely has a psychological and transcendental component to it. What we do in order to properly, positively stimulate the body. So just to give you a few examples, medicine of the brain, you can think of integrative traditional approaches such as mindfulness, meditations, body scan, guided imagery, prayer, exercise, specific neural breathing techniques, and so on and so forth. So medicine that is definitely working on the body structure, because we are not separate from our bodies, regardless if you're taking into account an embodied cognition perspective or your purely mechanistic materialist perspective, but a type of medicine that is mainly focused on the healing path. So let's go back to this treat, heal, cure component. So the healing process in itself has to do with making the body whole again, making our sense of self whole again, this integration and continuation of self. Think about the work by Mario Bunge in this regard, or all the work by positive and humanistic psychology for that matter. So the healing process as the connection between to heal, the healing element, health, as well as wealth, holy, whole, wholeness, all these etymologically related terms that have to do with this idea of reintegrating mind and body. Okay, for now we just assume this duality. Okay, we're not taking into account the third element, the spiritual element, the transcendental element. So this integration between what we perceive with our senses, with our body, what our body has to say about the way we feel sick, the way the disorder develops and makes sense in terms of pain perception, and on the other one, the way we feel on a more emotional, cognitive level, in order to say ethereal or transcendental level. So this is the healing part. The curing part, of course, the term itself could be pushed in a iatry perspective. Think about iatry as a term in the medical sense of this etymology. Think about psychiatry, for instance, as opposed to psychology, where the psychiatric component has to do with the treatment, with the cure, and psychology has to do with the study, with the science of the psyche. So one element is connected to that part, and the other element is predicated upon the fact that there is an assumption of fixing the problem. Now, I don't want to be unnecessarily polished in this sense. I do understand that claiming to cure someone is scientifically not that precise of a term, because again, we can only support the body in its work. So you're not fixing the problem, you're stimulating the natural process that already occurred in the body. But for the sake of argumentation here, to cure simply means to create a condition according to which the body will eventually find the best possible reintegrated self in a homeostatic sense, where infection will no longer be present, to give you an example. But there's an intrinsic difference between treating, healing, and curing, because the idea is this: if you treat, there is a connection between the provider and the patient. If you're healing, the connection goes beyond that and focuses on the integration of something that's been separated, disintegrated, dissociated. And in the third case, we want to work on the fixing last part of the process, which is very often, unfortunately, what medicine, especially in the Western biomedical model, has been understood to be. You're not preventive, you're not fostering appropriate health, You're just simply trying to avoid, mitigate, or control the possible worst outcome in this sense. Now, of course, what is kind of interesting is that in regarding to the term to heal, we could spend multiple semesters discussing the connection between wholeness and holistic, holism, healing, etc., and also spend some time distinguishing some, how can I say, folk etymology, so that there is a distinction between holism from holos, the continuation and the integration, and healing in terms of what you're actually doing, what the body is doing. But let's leave Let's leave that aside from a second. In terms of treating and curing, etymologically speaking, the assumption that curing is fixing the problem and treating is actually providing support, it's not really correct, because really, in terms of treating, treatment, treating and therapy are connected in a historical and pragmatic sense. A therapeutic intervention is there to treat, to support the patient, but it's not that the care is separate from cure. In fact, the cure is care, okay, etymologically speaking. They both come from the Latin cura, and the interesting thing is that curing someone, despite the fact it might sound very judgmental, can be applicable not just in the perception of body control, so curing a physical disease, but also curing a mental problem, curing even a spiritual problem. To give an example, one of the old terms for a priest or a pastor even was the Curato d'anime, so the person who takes care of the person's soul, not the person who cures the person's soul necessarily in a judgmental way, the person that is there to blame the person, but it's a person who provides support in order to remove all those obstacles to the person's soul in order to achieve this theosis, we would say in Eastern Orthodoxy, this connection to the enlightenment from the realization of one's own divine origin, so to speak. So to cure, it's not necessarily a judgmental word per se, despite the fact that it's less and less used in a medical context. Now, this is, of course, connected to what we said last week, or rather in the last 2 weeks, in connection to the sensus divinitatis, this sense of the divine, according to Alvin Plantinga, to give you an example, just one name, and that is predicated upon the assumption that in order for us to feel better, feeling better on a psychological level and also on a physical level, we get our sense of the divine straightened out, so to speak. Now, I do understand that this by definition is very judgmental. It may even be perceived as dogmatic, as in either you follow those rules, otherwise you'll never get better. And yet, I wouldn't consider that necessarily as an inner fallacy for this type of argument. To give an example, let's think about the connection between neuroscience and medicine. Now, there are things that are easily observed in the context of, for instance, brain imaging, and the only issue there is to verify whether what we observe is the ultimate truth. We talked about that when we mentioned the work by Bloom, for instance, and the fact that observation, it's not full understanding, it's just description of what you observe. But nevertheless, it's hard to argue against solid science if all your biological, neurological, and brain imaging apparatus claims to have found A. You cannot say that you can see B in that context. So science is pretty straightforward in that sense. And so you would say that according to this biomedical model, it is not, or it should not be perceived as unnecessarily judgmental to claim that I, as a doctor, for instance, am an expert in what I observe in your brain scan, to give an example. You might disagree with me in terms of what that means personally for my own healing process, but it would be really hard to argue against solid science. And that is why there are elements of this assumptions that are predicated on authority alone. Now, what do we mean by that? Well, authority alone, it's generally speaking not a sound argument in a logical, philosophical sense. So you cannot just say that someone is a good scientist because he is, or a good scientist, or she is a good scientist. You would say simply that this person's scientific study is more or less indicative of taxonomical errors, for instance, or statistical errors, etc., etc. So, in other words, you will not judge a study simply based on the authority of the physician that produced the study, whether she is a good physician or not. However, in the context of medicine, you can also rely on the fact that none of us is an expert in every field. We mentioned this multiple times, and so some level of authority is warranted. You would assume that the person went to medical school or graduate school for neuroscience, and because you don't have the depth of knowledge, you rely on the academic authority of the person to understand that that is probably the best recommendation at that point. So this is one element that is definitely true for the biomedical model. Again, hard sciences are harder to argue against. We talked about that in the in chapter 2. Now, what about the psychological process? What about the intersection between mind and body? Well, what Alvin Plantinga and others have claimed is that this sensus divinitatis, this awareness, this I don't want to use the term paranormal, supernatural, or how can I say this, or esoteric perception, because those are poorly constructed terms that sound very imprecise to me, at least. And then if you use the term paranormal or supernatural, what would you exactly mean by that? Do you mean that if something is supernatural, it does not have any neural correlates, natural correlates, biogenetic correlates? Well, I have to fully disagree on that. We have a brain for a reason, a very important one. And what do you mean by paranormal? It goes beyond what the norm is? Well, we're talking about medicine. We always work on normal distribution, statistical analysis in epidemiological sense, and I would much rather talk about outliers in this perception. When these outliers are justified on the calculations that you constructed or not, this is something that has to do more with mathematics rather than philosophy or theology. So I'm not particularly fond of those terms, but in any case, if someone like Plantinga claims that healing can happen the closer you are to the development of this sense of the divine, this sense of divinitatis, this will also warrant some level of authority. For instance, you could rely on a wise advice in order to feel better about yourself, despite of the fact that this advice will really go against everything you believe about yourself. And this is really not surprise. In psychology, this is an everyday circumstance, and in medicine is definitely the case. What might be good for you might not be perceived as such by you in this very moment. For instance, think about physical pain. If you are in excruciating pain, if you just had a rotator cuff surgery, for instance, the fact that I'm going to ask you, as your surgeon, to do some exercises in order to ameliorate the function of your shoulder will really be something that you won't like. You won't like on a physical level, pretty straightforward, and you might not even like on an emotional level, because pain has a way to cripple in all our senses. And yet, despite the fact that I don't feel good, I don't think it's good, I don't actually perceive that as good in my body, it is a good things to do, because you as a surgeon have that knowledge to promote my restorative element. So the same thing for this sense of divinitatis. Now, of course, because we're talking about the divine sphere, it's something that is not empirically verifiable, or at least not in the same way as an infection is, then the issue remains, okay, which one has the ultimate truth to promote, and is there any way out of too much dogmatism, too much theological and judgmental self? Well, one of the ways to address this would be either the very holistic and yet to some extent pop theological perspective that there are multiple ways to reach that sense of the divine connection, or the other one that each road, each pathway to this extra sensory perception, again I don't like the term too much, there are more proper and less proper ways, but each way contains some level of truth, so to speak. And of course, depending what system of belief the person have, this person might make a judgment in the sense, well, for me, this is the primary way. Other ways are good as well, they might not be good for me. Now, of course, this adds another risk, and the risk of missing judgment. Because in a statistical sense, you always want to make sure that you account for false positives and false narratives. So which area you would like to go to in order to prevent the biggest possible mistake? Would you venture on the risk of finding false positives, or would you venture to find the risk on on false negatives? And this is something that we will keep exploring. But yet again, the idea is this. If your self-perception on a body level, on an emotional level, cognitive, psychological, transcendental level is compromised, your very judgment will be compromised as a result of that. So you need to rely on another person. In other lecture, I always mention this: if you are struggling with a physical or mental disorder, it is always good to quote-unquote borrow someone else's brain or borrow someone else's heart. You find this in the lecture on depression that I linked 2 weeks ago. And again, just to remember what I mean by that, you borrow someone else's brain in the sense that you borrow someone else's knowledge, scientific knowledge, to know what's good for you despite the fact it might not feel good, physically speaking, to you. And you might borrow someone else's heart if you want to have this emotional support that you yourself cannot find within yourself, in the context of low self-esteem, for instance, or negative emotions, suicidality, and so on and so forth. So, all of this considered, we are talking about judgment, and one of the things that I would like to mention in this lecture about medicine on, off, and off the brain is the attitude of neuroscience and psychiatry toward what it means to be healthy, okay? To what it means to be cured, quote unquote, or treated, or successful, well-adjusted, another term that I find myself in disagreement with. Well, you also want to remove the sense of unnecessary criticism to begin with, because yet again, you don't know everything. I certainly don't, and assuming that you know more than the person treating you, it's also a false assumption, the same way as the person treating you should try to know as much as they can about you in order to avoid mistakes. Example here, psychiatry and mental health institutions, psychiatric unit. Now, in the context of judgmental medical labeling, medical jargon, medical terminology based intervention, the name that I mentioned last week, Franco Basaglia, it's still one of the most important names in the context of critical neuroscience. Well, how to sum up his work? Well, he was a brain scientist by definition, a psychiatrist, trained, licensed as a psychiatrist, and also a person who had a profound knowledge of philosophy. He also worked in an area of very integrative, transcultural components. He worked in Gorizia, which is in Italian. It's a city at the border between Italy and, back in the days, Yugoslavia, nowadays Slovenia. Gorizia is the Italian name of the town, of the city. Görz is the German equivalent, and Gorica is the Slavic, Slovenian in this case, name for the city. And so again, you have this Middle European connection between the Slavic, the Germanic, and the Italic counterpart, the Romance counterpart more specifically, that creates very interesting cultural milieu that provided support for a much more profound and analytical conceptualization of mental health. So long story short, he was instrumental to have the Legge Basagalia, the Basagalia law, approved in 1978, and that was a groundbreaking law that ultimately determined the fact that Italy to this day is, to my knowledge, the only country in the world where there are no psychiatric institutions per se. Now, of course, there are psychiatric units. I had part of my training at the University of Verona in the psychiatry and clinical psychology department, but we don't have locked units the same way as we have in the United States, for instance. And this is something that is connected to what we said last week about the anti-psychiatry movement. Although Basagalia himself was never a member of this movement, and again, I am very critical of the movement in its more extreme representations in the last 10-15 years, unfortunately. But the idea of a judgmental self where a person can actually pontificate on what is good for the person, and if the person does not abide by those behavioral, emotional, social, cultural rules, then this person has to be locked in a psychiatric unit. This is something that Basagalia really strived to get rid of on a moral, on an ethical, on a clinical, medical, and ultimately on a legislative sense. Another fascinating factor, and possibly one of the core components of this course that I really want to get across, is that when we talk about words, words have meanings, words have weight. And by that I mean a weight in a neurobiological sense. Think about the story and the work of Florence Nightingale. I am positively biased toward nursing as a profession. I mention this all the time. And Florence Nightingale exemplifies one of the highest possible ideal in this profession. She was also someone who suffered a lot physically and emotionally and socioculturally, just because of the area she was exposed to in her work as a person, as a provider, as a nurse. And whenever we talk about Florence Nightingale, we talk about fibromyalgia. And in a course on critical neuroscience, fibromyalgia, I think it's one of the best example of the connection in practice between mind and body. We're not just talking about somatized or somatoformic issues. We really talk about something that is very often harder to understand from a strict biochemical perspective. Think about pain perception, think about pain threshold, think about pain sensitivity. And yet all this very important element of interaction between mind and body in the context of depressive state, in the context of fluctuation of moods, in the context of less optimal cognitive interpretation state, and so on and so forth. So if one were to ask you, what did you learn in critical neuroscience? Is there any specific examples you can give me on how the understanding of the theory, the theoretical construct, the words, the philosophy of neuroscience has a direct application to medicine, for instance? Well, fibromyalgia would be one of such areas. So let's try to better understand what we're talking about here.
So fibromyalgia is a condition that really causes pain pretty much all over the body. It's often accompanied by fatigue and problems with mood, with memory, altered sleep, and emotional distress, mental distress, and this increased sensitivity to pain. That affects the entire self, and so it's a great example for the connection between mind and body. A great problem in this context is really the clinical assessment of fibromyalgia, given that it's still remains a mystery to a very big extent to the scientific community. And overall, it's very much recommended to have a comprehensive clinical and diagnostic assessment, including a complete blood test with complete blood count, erythrocytes, alimentation rate, and of course a psychological assessment as well, because as we mentioned, it's not just about pain as if there wasn't enough, but it's about a deeper understanding of the perception of pain. An example in this context is research by Müller, Schneider, and Stratz. Research according to which we can identify at least 4 typologies of fibromyalgia with related best clinical treatment strategies and strategies for management. The first one has to do with extreme sensitivity to pain, but without associated psychiatric conditions, 5-HT3 receptor blockers. The second one, fibromyalgia and comorbid pain-related depression, for which antidepressants are recommended. The third, depression with concomitant fibromyalgia syndrome, also treated with antidepressants. And of course, psychotherapy, this is always the primary go-to clinical treatment. And finally, for fibromyalgia due to somatization, which in itself is connected to psychotherapy, I wouldn't say alone, but primarily in comparison to point 2 and point 3.
Finally, we also need to discuss the connection between words and theoretical frameworks and the way we interpret health, the healing process on a personal level, as well as on a social level, on a social policy making perspective. Now, this has to do with safety, with privacy, with understanding, with note-taking, and so everything that is connected to HIPAA rules and regulation, to the way EHR works, so electronic health records work, on the way SOAP notes work, and SOAP notes are some of the most commonly utilized clinical notes where the acronym indicates subjective, objective, assessment, and plan, so SOAP notes. Play a very important role in the way we understand our patient. And again, keep in mind that understanding a patient simply means knowing what to do with the patient, okay? And by that I mean in cooperation with the patient. Think of what we said etymologically speaking about the SYN or CUM. So SYN in Greek, CUM in Latin, is togetherness. So we're not going to do something with the patient as in I have to deal with the patient in a very judgmental and callous way, but I have to work with the patient because the patient-provider relationship is essential for the amelioration of the physical and psychological presentation of this person. So all of this is extremely important in this section of our course. Wonderful. This concludes week 7. We passed the midterm again. Congratulations to all of you. We will continue next week, week 8, talking about medicine on, off the brain, and we will venture into some more pragmatic applications of medicine in the context of neuroscience. So we will talk definitely about neurology, neurosurgery, and theoretical and practical aspects of these fascinating subfields within both neuroscience and medicine. Thank you very much. I will see you all next week. Bye-bye.